Good morning. Thank you and welcome to Seattle, and thank you for honoring us with your presence here. I'm David Stout. I'm the Chief of Cardiac Anesthesia here at the Heart and Vascular Institute. I work with Dr. Barnhart, Dr. Youssef, Dr. Lair, and Dr. Ryan and Dr. Tepley, which is all our surgeons here. We have a robust, minimally invasive program, and we'd like to talk to you a little bit about the anesthesia side of this, which is a critical piece. You have, as a surgeon, now asked your anesthesia colleagues to do a significant portion of what the surgeons typically have done, which is including the heart preservation and the decompression of the heart. I am a paid consultant from Edwards. That's my only disclosure. I will say that Edwards has the only products for minimally invasive surgery for anesthesia, so there's not exactly a lot of competing products. Having said that, I don't drive the use of these. It's really driven by the surgeons who want to do these procedures, and obviously driven by the patients who want to have minimally invasive surgery. I'm going to give you a brief overview of what the anesthesia experience is with minimally invasive surgery. This is specifically a presentation for anesthesiologists, but I want to show to surgeons, and I actually do show to surgeons and have before, because I want you to know exactly what you're asking your colleagues to do. In kind of at the beginning, I just want to kind of explain my experience with minimally invasive surgery. It's similar to Dr. Barnhart's. I actually started with the HeartPort system in the late 90s. I was trained by the original HeartPort company on dogs, and I had never held a TE probe in my hand until they had taught me to do it in a dog, and learned how to put retrograde coronary sinus catheters in. I went through the period of trouble with the HeartPort system, and then went through a number of years where we didn't do it, neither did anybody else. Dr. Barnhart came back and wanted to do minimally invasive surgery on valves, which turns out to be the correct target, because the target we were doing in the 90s was coronary artery bypass grafting, which was the wrong target. And so I was interested in getting back in and helping, because I had been paying attention to the literature as well and seeing that it was of value. But it did give me pause, because I had had my experiences in the late 90s as well. So from the anesthesia perspective, there's two things that need to happen. We put in the retrograde cardioplegia cannula, which has already been brought up today, and we also put in the EndoVent. And I'm going to show you how we do that. If you have questions, please interrupt me. I'm not going to go to incredible detail, because you don't need to put those in, but give you an idea of what you're asking your colleagues to do. I'm going to move right ahead. Dr. Barnhart's already talked about a team approach to this, trying to start simply, moving from simple cases to more complex cases. How we actually all learned was putting retrograde cardioplegic catheters in and pulmonary artery vents on regular cases. We weren't doing minimally invasive cases at all, and the value in that was that there was no pressure. We could have the surgeons go make rounds, go drink a cup of coffee. We'd put in the minimally invasive lines. If they went well, great. We'd use them for the case. If they didn't, no big deal. We would just go back to our usual manner in doing a case. Once we had some experience putting the lines in, it became easier. And we actually, at that time, I did it with one of my colleagues. So two people learned at once. We had two anesthesiologists, one kind of running echo, the other one putting in lines, and the next day we'd switch. And so in a very short number of cases, 5, 6 cases, we had some expertise in doing that. And we then added more people to the team as we had more and more numbers. And currently we don't have everybody in our cardiac anesthesia team doing minimally invasive lines. I think it's probably not ideal. We try to pick the people who maybe have the mentality for it, or the interest, the skills, and it's better, I think Dr. Barnhart mentioned, to have a core team that's interested and does it a lot. It's like anything else. You do it a lot, you get better at it. The first part is called the ThruPort ProPlege peripheral retrograde cardioplegia device, and what it is a way for us to deliver cardioplegia retrograde, but we do it from the neck. You need to have a small incision, so we need to take those two cannulas away from the small incision that's going to be used, for instance, like a mitral or an aortic. We want to get rid of both the retrograde and the vent. So I'll give you kind of an overview of this device. It looks quite a bit different than the one you guys put in, which is obviously a sterile device that you use on the field. This is the proximal end of it, which is controlled by the anesthesiologist. We have a balloon at the tip of the catheter. We also have a way to give cardioplegia, which is this second green stopcock. This handle here actually allows me to flex and unflex the tip of the cannula, and then the white stopcock is just the pressure line. This just shows you how it flexes. If I have it all the way forward, it's somewhat straight. If I pull it back, it flexes even more, and that allows for changes in the angle of the entrance to the coronary sinus. We also have some markers on here and a longitudinal line that keeps us oriented when we're putting it in, because we are putting it in from the neck using 3 modalities, which I will show you. We're using transesophageal echo, we're using fluoroscopy, and we're using pressures. What we try to do is make a very efficient but safe entrance to the coronary sinus by using all of our modalities in a very measured, thoughtful way. As you all know, cardioplegia can be valuable, used in both modalities, which is antegrade, shown here in this kind of yellow-orange, and then retrograde through the retrograde cardioplegia. Some people prefer one or the other. Most surgeons, and I am not a surgeon, but many surgeons think that using a combination of both might be the ideal situation. Because, of course, you get different territory with different modalities. From the anesthesiologist's perspective, this is simple, straightforward things for you, but the anesthesiologist has to think about the heart a little bit differently. You look at the entrance to the... Do I have a pointer here? Oh, it's right there, yeah. The entrance to the coronary sinus from the anesthesiologist's perspective, and... Yeah. Is there one button at the top? Oh, there it is. So from the anesthesiologist's perspective, we're used to putting in the, PA vent through the tricuspid valve, which is right here, which is this big, huge structure. But that's not what we're going for. We're going for the coronary sinus, which is this small little structure. And so it takes a whole different set of skills for the anesthesiologist to do that from the neck and be able to do that in an efficient manner. This is what the coronary sinus looks like from the back of the heart. Not a surprise to you, but that's where we want to enter. We want to have the coronary sinus catheter past the middle cardiac vein, clearly getting both the left border of the heart, but also the right ventricle. We don't want to be as far out as the great cardiac vein, but we don't want to occlude the posterior ventricular branch either. So how we do this is we put in actually 2 internal jugular sheaths on the right IJ. You can put in the coronary sinus catheter from 2 places. One is the right internal jugular vein. The second is the left subclavian. You cannot put it in really from anywhere else. You can't put it from the right subclavian vein because it can't make the bend. You can't put it from the left internal because you can't make the double bend to get down. So it's just the 2 locations. We virtually put 99% of them from the right internal jugular vein. Once we get into the coronary sinus, we'll see some ventricularization, and that tells us tells us from the hemodynamic perspective that we're there. We have other ways to identify that. When we're putting in the catheter, we start off with it in the straight position. I go down the internal jugular vein. The entrance to the coronary sinus, you'll see. Oh, sorry. It just shoved me off. Let me just close whatever that is. Seems to be okay now. Sorry about that. So if you're looking down the internal jugular vein, and this is the internal jugular vein, the entrance to the tricuspid valve, which is what usually the anesthesiologist is trying to hit with the pulmonary artery catheter, is at about 9 o'clock on the clock face. The coronary sinus is down here at 7 o'clock, and again is much smaller. I will keep my curl of my coronary sinus catheter posterior, and on transesophageal echo, I get a modified bicaval view as my primary goal. We can use two views. This deep 4-chamber view, which is, this would be the RV would be down here. I can't quite see the tricuspid valve, but it should be about right here. It's probably just open at the moment. But the coronary sinus sits here. This is a fantastic view. The problem is it's very difficult to see the cannula as it's coming down. And so it's if you can't see the cannula, you can't put it in. You have to be able to see the cannula and you have to be able to see the target. So the modified bicaval is a much better view in the sense that we can come down the SVC, we can track along the intra-atrial septum, and here is the coronary sinus. This, interestingly, is a branch right there, which is the middle cardiac vein. So actually seems pretty straightforward. And most of the time is. We use TEE, as I mentioned, and you've seen the views. We flex the tip as necessary, and we get it to go into the correct position. I also use fluoroscopy, and I'll briefly touch on that. Anesthesiologists typically aren't trained in fluoroscopy. We at our institution have actually, I think, gotten quite good at it over the years. We do it A, for efficiency, B, for safety of the patient, and 3, just to document that we're actually where we want to be. At the conclusion of putting in the coronary sinus, I'll shoot some contrast and make sure that I don't have a PLSVC. Also make sure that I'm covering the entire heart with cardioplegia so that I can look at the surgeon and say, yes, that retrograde cardioplegia is in the correct spot and is going to function appropriately. This particular view right here shows that it shows kind of where the entrance of the coronary sinus is, which is this little area at the left border of the spine. If you're above the diaphragms, you can only be in two places, either across the tricuspid valve or in the coronary sinus. That's one thing we use. We can tell that with pressures. We can tell that with echo. This is what the coronary sinus looks like. Catheter or the ProPlege in the correct. It goes from a kind of a modified J or reverse J to this U-shaped. And this is typical of the final position of the coronary sinus catheter. The only other place it can look like is if it's across the tricuspid valve, but again, we'd see pressure gradients there. I then inflate the balloon, and I do that very slowly, and we'll see some ventricularization. I inflate slowly because the compliance of the coronary sinus is such that it takes a while to equilibrate until you see that distal pressure and the equilibration of the ventricularized phasic pressure. So we can do, as I mentioned, a couple of things to identify that we're in the right spot. On echo, I can see the catheter here in the coronary sinus, but that doesn't tell me how far in I am or whether I have good coverage. So we use, again, contrast with fluoroscopy, and then I can tell that I'm way over here in the left border of the heart, that I've got middle cardiac vein, and we do that routinely at our institution. We then lock the catheter in its place, and we move on to the next catheter, which I'll talk about. There is some troubleshooting along that we look at. This is also of value if I have gone down the posterior ventricular branch, which can happen. That's what this one is here. This is not ideal. We'd like to stay in the main coronary sinus. Or if I've gone down the middle cardiac vein, that's clearly not going to work because this whole rest of the heart's not being covered. So fluoroscopy, again, tells me that. I have been able to, there's several things I can pull back, put a little more flex in the tip, get in the main coronary sinus. I've also been able to pull back, advance a wire out the distal tip of the coronary sinus and redirect that to the place where it needs to go. Also allows us a couple things. You can see a valve here. You can see that we're maybe kinking the coronary sinus, and you need to kind of relax that stress on the coronary sinus. If you're going to use a wire, you obviously have to use fluoroscopy. You don't know where you are. The wire can be great adjunct. It allows us to get past a valve, get past a bifurcation that the catheter wants to track the wrong direction from where we want it to go. And I found myself to be using wires more and more and more with the coronary sinus. Not that I can't do it with a wire. I just find that it's quicker, more efficient, and I actually think once you know some of the basic techniques, I think it's safer. Some troubleshooting with the line. The perfusionists will complain immediately that the line pressures are high, but they have to understand that the catheter is this long and it has its own inherent resistance, and they have to get used to higher line pressures, but the flow will be just fine, and they just have to understand that the pressures will be higher than they're used to. The second catheter that we put in is the EndoVent catheter, which in a way seems like the most simple of catheters because it is really analogous to a pulmonary artery catheter that's used commonly in heart surgery. But there are a couple of differences. The EndoVent is it's very long, and Dr. Barnhart alluded to it. It is very soft and pliable. It's almost like a piece of cooked spaghetti, and it can be one of the hardest things can be just putting it through the introducer itself, which seems crazy because that's just getting started. But it is so flexible that can be a problem, and there are a couple tricks to that. When anesthesiologists come and learn from us, we kind of teach them a few of the tricks. But again, what we do is just put it down into the pulmonary. That says nothing new here. Put it into the main, there's the PA valve, pulmonary valve, so we'll put it in the main PA right here. We get about 40 cc's a minute of flow out of this device. It's again put in just like a pulmonary artery catheter, except for most anesthesiologists put it in with pressure only, and I actually never put it in with pressure only. I use fluoroscopy only, which I've had fluoro there, putting in the coronary sinus catheter, which I do first, and put the PA in second. The reason I use fluoroscopy is this device, even when it gets past the introducer, likes to curl up in the innominate, in the SVC, and you can see that on fluoroscopy and do something about it immediately. This is just showing how it goes out in the main PA. You do it with a balloon. It's really analogous to the PA that we use for any other kind of a procedure. We flush while we're putting it in. These are just a couple of, this is classic. It does it all the time. Goes up in the SVC. I actually see it, or innominate. I see it up here in just curling up at the top. Sometimes it'll curl down here. And what I do as an anesthesiologist is actually do something different than what we normally do, where we're all trained to keep the tip going first. I've learned from the cardiologists who don't care that much about that, and they're happy to have a curl go down first. And so I just push the curl down and then try to gently make that curl unravel. Here, and this would be a typical example there, it's curling in the atrium. Pull back, get the balloon to go up. But again, you can get 40 cc's of flow out of it, and it'll keep your heart empty. And people poo-poo that how much decompression can you get, but the surgeons are happy with it when we have the vent running. Thanks.